think CMDA has been a valuable resource to our relationship from the beginning, in the sense of that's literally where Crystal and I reconnected and started dating after we had been away from each other a couple years in college. In that way, it's been very monumental, Wouldn't have this without it.
Yeah, for me, I think about family in particular, especially being a healthcare professional, the nuances of being a mom, for example, being married and having that role in my career is not an easy one that a lot of people can help me navigate. So to be around people that understand, they get it. I don't have to explain it. Like, they understand, especially when we were pregnant with our first child, kind of those changes that we were going to go through. So to have a community of people that get it and can pour into us. I mean, there is no shortage, and we thank God, of people in the community that we're in that are part of CMDA that have poured into us and spoken life into us and encourage us that we can continue to glorify God in our family, of course, but then also still use our skill sets for His glory as well, where He's placed us. So that has been monumental.
It's inspiring to hear how CMDA is making a difference in the lives of Christian healthcare professionals like Matthew, a physical therapist, and Crystal, a dentist. The Maddox family serve in Richmond, Virginia, and their story is just one of many we hear from healthcare professionals across the country. This also speaks to why your financial support for your CMDA annual fund is so important. Thanks to generous supporters, we've already received $457,481 toward our $640,000 matching gift challenge. But we're not there yet. With just over a week left, your gift today can still have double the impact. Visit cmda.org/give or call 888-230-2637 to make your impact. Thank you for your support. You're listening to CMDA Matters, the weekly podcast of Christian Medical and Dental Associations. Here's your host, Dr. Mike Chubb.
Welcome, friends, to CMDA Matters, where we explore the issues that matter most to Christian healthcare professionals. Whether you're in healthcare, married or otherwise related to a healthcare professional, or you're just simply interested in how God is working through Christ followers in patient care and beyond, I'm so glad that you're here. As we enter the final days of CMDA's fiscal year, I want to extend another heartfelt thank you to every one of you who has generously contributed toward our $900,000 goal for June 30th. Your support empowers CMDA to educate, encourage, and equip Christian healthcare professionals across every specialty, enabling them to live out their calling and share the hope of Christ with those that they serve. On today's episode of CMDA Matters, we're diving into one of the most talked about pro-life research studies of the year, a groundbreaking report from the Ethics and Public Policy Center that's raising serious questions about the safety of the abortion pill called mifepristone. My co-host for the program, Dr. Brick Lance, and I are honored to be joined by the study's authors, Mr. Ryan T. Anderson, Ph.D., president of the Ethics and Public Policy Center, and a leading scholar whose work on ethics and social philosophy have been cited even by the U.S. Supreme Court justices. He's joined by Jamie Bryan Hall, EPPC's Director of Data Analysis, and he's the lead statistician on this largest known study of the abortion pill safety. Jamie's rigorous expertise, shaped by advanced degrees from Harvard and years of policy research at the Heritage Foundation and even the CIA, was critical in uncovering adverse event rates more than 22 times higher than the FDA currently reports. Today we're going to unpack their analysis of more than 865,000 insurance claims, exploring troubling findings from hospitalizations and infections to concerns about misdiagnosis, coercion, and even human trafficking. This conversation not only exposes critical gaps in women's healthcare, but it also affirms the truth that every life, mother and child, holds God-given value. As we pursue greater transparency and accountability, we hold fast to the hope that truth can lead to not just better outcomes, but to care that honors both life and the Creator who gives it. Let's dive in. Well, today on CMDA Matters, I have an awesome combination. A co-host today, Dr. Brick Lance, who's coming to us all the way from the Balkans, from Croatia, our Vice President of Advocacy and Bioethics. So welcome, Brick, from across the pond.
Thank you, Mike. It's a pleasure to be here.
And Brick, it was you who, I'm in the midst of a very busy national convention. You grabbed me by the arm and said, I got something important to tell you. I know you're busier than a one-armed paper hanger, but there's a study coming out here at the end of April from the EPPC, the Ethics and Public Policy Center, and I think you need to know about it, and we need to get on board. And so today, we have the authors from that study that came out April 28th. The title of the study, The Abortion Pill Harms Women. Insurance data reveals 1 in 10 patients experiences a severe adverse event. And so for our listeners, I'm guessing many of them, because this has been all over the news. So I want to thank both of you gentlemen, Jamie Hall and Ryan T. Anderson from the EPPC. Welcome to CMDA Matters, and thanks for getting this buzz going.
Thanks for having us. It's a pleasure to be with you.
Well, Ryan, you've been now at the EPPC at the helm for how long?
4.5 years now.
Okay.
Time has gone by fast. Yeah.
And you're the president. Before that, you were at the Heritage Foundation, I believe, and that's also where, Jamie, you were prior to coming as chief statistician, the mathematics guy, and therefore you're the lead author on this paper that I just realized this afternoon. So before we jump into the paper and how monumental it's been for the pro-life movement and information about abortion in general, Ryan, tell us just briefly about the EPPC and what is its mission?
We were founded, next year will be our 50th anniversary. That's the kind of clearest way to give some historical context. We were founded in the bicentennial year of the nation. And so next year when we celebrate the 250th anniversary of the nation, we'll be celebrating our 50th. Our mission is really to be both pro-America and pro-Bible. And we think those two things have something to say to each other. We think the Jewish and the Christian theological traditions and the American political and constitutional tradition can mutually benefit each other, and that the founding had something to do with a Christian vision of the human person, a Christian understanding of the role of the state and the limits to the state. And our job, EPPC today, is to really think through, what are the public policy questions, the ethics and public policy questions, where a distinctively Judeo-Christian moral vision will make the biggest contributions. And so a lot of our most pressing work today really focuses on the question on what it means to be human. Who and what is the human being? Because, many of our most pressing policy debates really have underlying roots in metaphysical and moral and philosophical and theological debates about the nature of the human person. And, that's partly what we're discussing today with the mifepristone study. I brought Jamie to EPPC, what was it, Jamie, like a little over a year ago, because historically, we're a bunch of philosophers, theologians, lawyers, policy wonks. We didn't really have any number crunchers. And, Jamie has 2 degrees from Harvard in math and applied math and statistics and things like this. And I was like, we need a director of data science, because there's no tension between faith and reason. And there's no tension between what the more humanistic liberal arts, philosophy, theology, law would be revealing on these questions, and what's good data, when well analyzed, would be revealing. And so we try to, draw from, all of the disciplines that can shed light on these questions that matter.
Well, you had mentioned what it means to be human, and we at CMDA certainly believe that the unborn is a human being, and a human being basically from fertilization onwards. And mifepristone has dramatically increased as far as use the past few years. And some say now it's somewhere between 60 to 70% of all abortions. And obstetricians, gynecologists have known and seen these complications that you allude to in the paper, including hemorrhage, infection, sepsis, subsequent surgery, hospitalization. But these physicians have not had the data or statistics to actually point their finger on how frequently this occurs, other than they see it in their practice. So what inspired both of you to collect this data? And not only what inspired you to collect it, have you had pushback from any other folks, including the medical community, health insurance carriers, or others during this process?
There's a lot to say. I mean, part of it was, I first started working with, the people who would eventually become our kind of data brokers. I guess it was over 2 years ago. And, when Jamie came to EPPC, he started working with them. Just thinking through, what are all of the questions? Because it's not just mifepristone, but there are a variety of questions that would matter both to EPPC and to CMDA that, real life insurance data could shed light on. Questions about gender ideology, questions about euthanasia, assisted suicide, questions about beginning of life. There's a lot in this data that could be useful. When we saw which way it was likely that November election would go, we said, look, there's going to be a window of time where we might have a more receptive HHS and FDA, and they might be more willing to reconsider the missteps from the Obama and the Biden years, right? All we're asking them to do, based on this initial paper, is to go back to the Clinton regs, right? Ultimately, this isn't a secret. There have been some liberal journalists who are like, we caught the co-author of the paper saying that he wants to ultimately get rid of the abortion pill. I was like, yeah, I said that on a live webcast that we archived and then tweeted out the link to. Yes, it's no secret. We think the abortion pill kills unborn babies. That's what it's intended to do. So we think killing unborn babies is unjust. So we don't want to see this approved. But for this purpose, it was merely about the safety to women and therefore the threat to women's health, which is why when the Clinton administration approved mifepristone, they had a whole host of safety regulations. And one by one, first the Obama and then Biden got rid of those. And we thought if the data shows what it does show, that this is really, really unsafe, and it's something that I would imagine many of your listeners would know from firsthand experience, right? Especially your listeners who are OBGYNs or ER doctors, then this would be something that they couldn't turn a blind eye to. Right. And that whoever the new head of HHS, the new head of FDA would be, because back when we started working on this, we didn't know, they would have to take it seriously. So let me invite Jamie in to say a little bit more about what we found, just because we haven't yet
gotten the results yet. Yep.
That's more or less what motivated it, because we're located in DC, and so we're always thinking through not just how can we think big thoughts, but how can we think big thoughts that would then be actionable, because we want to see change.
We expected to see much worse numbers than were on the FDA-approved label for the drug based on what doctors we know were telling us, but we didn't expect it to be necessarily quite as bad as what we found, right? The FDA claims that less than 0.5% of women who take mifepristone experience a serious adverse event. It's right there on the label. The abortion industry will use that to say that it's perfectly safe, effective, safer than Tylenol even. But when we look at this real world data with over 850,000 observations of women who took the drug with whatever conditions they had when they took it, whatever healthcare quality that they received over the course of the process, what we actually found was that 10.93% of women experienced a serious adverse event. So it's up 22 times what the FDA was allowing to be published on the drug label. And we're talking about a wide variety of events, things like infection, sepsis, hemorrhaging, the requirement for blood transfusions, hospitalizations, ER visits, and so on down the list. So those things that are included on the FDA label, but also other events that were not included or not quantified on the FDA label, but that were mentioned as potential serious adverse events of the drug. So we were very comprehensive. We had assistance from a panel of doctors in classifying the different events, whether they were serious or not, whether they were related to the abortion or not, to make sure that we were only counting serious adverse events that were actually related to the abortion. And even with that very, very careful consideration of what to include and erring on the side of caution, we were still finding 10.93% of women with a serious adverse event. To be a little more specific on exactly what those events were or how common each of them were, for example, we found that almost 5% of women ended up in the ER for treatment for a serious adverse event related to the mifepristone abortion. We found that about 0.66% actually ended up being hospitalized longer term because of the side effects of the abortion. We found hemorrhaging in over 3% of women, infection in over 1% of women. So it's a wide range of different complications. Perhaps one of the most interesting and surprising things that we found was actually related to ectopic pregnancy. There were over 3,000 women in our data who were diagnosed with an ectopic pregnancy only after they had already taken mifepristone. But the label says, don't give this to women with ectopic pregnancy. And the original safety protocols that were in place were designed to help make sure that women who had ectopic pregnancies were screened so that they were not given the drug. Well, now actually you end up with over 3,000 cases where the woman takes mifepristone and only finds out afterwards that she had an ectopic pregnancy. So we're talking about serious problems here that are being missed in some cases because of the changes in the safety regulations that were put in place under the Obama and Biden administrations. That's why we specifically are saying, let's go back to what was in effect under the Clinton administration at least.
So originally, I mean, those Clinton regulations required 3 in-person doctor visits, and one of which was to ascertain the age of the unborn child and the location. Because as Jamie said, like, this is a very unsafe drug to administer to someone who has an ectopic pregnancy, right? Because, it could rupture the fallopian tube. It could cause not only fetal death, but also maternal death. And so to find that there were over 3,000 women who only after being prescribed mifepristone, if you're doing telehealth and mail order chemical abortion, there's no way that the doctor via Zoom can ascertain the age or the location of that unborn child, which is why originally it was a requirement that it was an in-person doctor visit and an in-person dispensing of the drug. And first Obama and then Biden, got rid of all of these.
Jamie, I just wanted to ask, it's just staggering, 865,000 plus patients, so much data. How hard is it to get insurance claims-based data? And is it very costly? Do you get pushback when people understand what you're pursuing?
It's certainly costly, yes.
Yes, I mean, so there are at least a dozen data brokers who, sell this data. And our listeners should know, like, everything about us is for sale. Our smartphone data, but so too our insurance data. They de-identify it, right? So you can't tell that it's your health insurance claims or mine. They make it anonymous, but they do allow you to see the health journey of a single patient, right? And so we can track, for this particular patient, 45 days out, what were the complications. So it's all for sale, and it's for sale because if you're a hospital, if you're a healthcare provider, if you are a health product manufacturer, you might want to see, well, what are the trends in insurance claims? And if, I see more and more people are using, this medical device or that medical life, or more and more people are experiencing this medical condition or that medical condition, it might actually lead to, various, research and development and production changes. So there's a commercial reason for this data. We then also realized, wait, there's a purely kind of public health benefit to this data. Marty McCary, the new commissioner of the FDA, he's published 3 different studies using insurance claims data. So it's used both in academic medicine, it's used in industry, and now, we've used it to actually think through, public policy and public health. Yeah, so I guess, does that address?
Yeah, so it's interesting. Yeah. As a practicing physician for 34 years in the field of orthopedics, some claims data reporting has changed the field of orthopedics. I think it's involved in every specialty, so not just obstetrician gynecologists. So I guess my question, what other claims data reporting are you guys looking into? Be curious. And how long did it take you to collect this data? Because this is an enormous volume of data that you collected?
We have friends who have the data, right? So we're working with them on the project. So we personally didn't go and collect the data. We got an agreement in place. We have to keep the specific identity of the data vendor confidential under that agreement. We've gotten a little bit of flack for not revealing that. But as you mentioned, like, claims data has changed the medical industry. And a lot of the folks who are criticizing us are very well aware of the existence of claims data, of the fact that so many vendors offer this data, and they just know that most people don't know this. So they're trying to ding us, trying to say that we're being secretive, when it's data that anyone could buy if they had the resources to do it. We're able to analyze that data with a team of data scientists, analysts, engineers, along with the doctors who helped us with the classification of all of the adverse events and helped us make sure that we had the right procedures in place to identify the abortions, and then look over the 45 days after the abortion at all of the diagnosis codes, the treatment codes, and the prescriptions that were provided during that time in order to identify our serious adverse events. So it was a very rigorous, lengthy process involving a lot of people. We're the public face of that.
So I'm curious, so you included what we call the serious adverse effects, not the mild or the moderate. And it's my understanding, correct me if I'm wrong, you did not include deaths in the serious adverse effects. So my question is there going to be some other reporting coming out of this data?
We certainly intend to report more out of this data. We have a whole series. In fact, so the first report dealt with the serious adverse events. We had a second report come out a couple weeks later looking at the efficacy of mifepristone, finding that it's about twice as likely to fail as what is indicated on the label as well. Of course, from our perspective, if it doesn't work, that's great. We don't want the baby to die. But from the FDA perspective, if it doesn't work, that should be a factor in their consideration of the safety and the efficacy of the drug. Certainly the manufacturer wants it to work each time. So we looked into that. We're looking at the effects of the abortion pill on the most vulnerable women in a future paper. So looking at those who are disabled, looking at minors, women who've taken mifepristone multiple times over the course of multiple pregnancies. So we're going to dig into this in a lot of different ways, including hopefully in the future being able to link the data that we have to death records farther upstream, and then it'll come down to us de-identified, but to be able to say, okay, well, actually, how many women who take this drug ultimately die from complications of the drug? Of course, that's, at this point, in theory, that's the only thing that a doctor who prescribes mifepristone is actually even required to report in terms of serious adverse events after the changes under the Obama administration, is whether the patient dies, as if that's like the only measure of how safe and effective the drug is. But even in that case, when you have mifepristone being given to women through telehealth visits, through the internet, who never really interact with the doctor, how's the doctor even going to know if the patient dies? So I'm sure that the official reports are undercounting deaths. We don't want to put out something else that undercounts deaths because of incomplete data on our end. We want to get the full picture of the death data before we put anything out talking about death rates from mifepristone.
Before we continue with this week's episode, here's a special announcement for you. There is such value and encouragement in staying connected with other Christians in healthcare. That's why the root of CMDA's ministry is in campus and community ministries, because you shouldn't have to face the hardships and struggles of both your healthcare training and career alone. We are here to walk alongside you and be a resource. With more than 80 local ministry groups and over 320 campus chapters around the country, you can find connection with your colleagues through CMDA. For more information and how to find a group in your area, Visit ccm.cmda.org. Have you heard the news about CMDA lifetime membership? When you become a CMDA lifetime member, you make a lifetime commitment to the ministry of CMDA. More importantly, you make a lifetime investment in bringing the hope and healing of Christ to the world. We've recently lowered the cost of lifetime membership, and it also means no annual dues payments. Plus, you gain access to exclusive resources and events available, like the special lifetime member reception at the CMDA National Convention. To learn more about becoming a lifetime member, visit cmda.org/lifetime. Let's jump right back into this week's episode.
Well, Ryan, that's a nice segue for me to ask you. There have been all kinds of responses, and I'm sure you and your team at the EPPC are quite delighted with the kind of response at so many different levels, including, you mentioned Marty Makary and the FDA. So clearly the FDA could open up the door and require more complications, adverse events, require them to be reported. But what would you and Jamie like to see happen now from the FDA in terms of going back and doing a study? I mean, they could just do something superficial to make everybody happy or try to. What would you like to see happen?
Sure. I mean, so look, we have said you don't need to take our word for this. Like, there's a huge replicability crisis in science. We don't worry about that for this study. We are fully confident that if they look at the same exact health insurance data that we did, and there's nothing unique about our data, right? We have Medicaid, Medicare, TRICARE, VA, almost all of the private health insurance except for closed systems where the provider and the payer are the same, like some Kaiser services. So what we've more or less encouraged them to do, and my understanding is what now both Secretary HHS Kennedy and Commissioner Makary at FDA have told Senator Hawley is that they will do, is that they'll do a full investigation and a study into the safety of mifepristone. They haven't said exactly what their methodology is going to be, but what I hope they do is that they look at all of the government health insurance data, that they buy the private health insurance data. I mean, they don't even need to pay for the public health insurance data because it's their own data, right? They can go to CMS and get Dr. Oz to, help them with this. Just look at the same data we looked at. This is real world data. There is value to clinical trials. There's also value to the real world health insurance claims data. One is being done under ideal circumstances, the clinical trial. This is being done in real world circumstances where not every patient is otherwise in perfect health, where not every protocol is followed to a T. Like, what does it look like for a real patient, the way that mifepristone is prescribed and dispensed today? The studies that were relied on earlier were relied on when they were following all of those original Clinton-era safety procedures. Our data starts in 2017, which is the year after Obama got rid of the major protections. It runs through 2023. We're hoping to acquire 2024 data to look what has happened since Biden got rid of some of the remaining safety procedures. So what we hope is that FDA will do its own study. We're fully confident that if they do, they will find exactly what we found. If anything, their numbers might report a higher rate of serious adverse events because we intentionally aim to be conservative to not overstate what we found in the data. And then what we would like to see them do is that at the very least, they should reinstate those original safety protocols, right? The in-person doctor visits, the in-person dispensing of the drugs, safety protections to at least make this safe for the mother. And then we can have a conversation about whether or not this is ever safe for the baby, because obviously it isn't. But you have to walk before you run, and so we're taking the steps to get to the ultimate objective, which is to make sure that both mother and baby are protected and cared for.
Yeah, it is interesting because when this was approved in 2000 under the Clinton administration, there were these safety protocols. Part of the reason is that we really did not know what the adverse effects were going to be of this drug. And as data was collected, unfortunately, the FDA and others collected very poor data, to say the least. And so this is quite valuable data. So let me go to the paper itself. And under figure number 1, you list the complications, including sepsis, infection, transfusion, hemorrhage, hospital visits, ER visits, ectopic pregnancy. a variety of different life-threatening adverse effects. So let me just first state, and you can restate for me, Ryan, that there's no overlap between patients. In other words, this 10.93% is of patients having at least one adverse effect, because some have multiple adverse effects. So correct me if I'm wrong in stating that. Yep. But if you could clarify on the other abortion-specific complications of 5.68%, could we get a flavor of what some of those others are?
Sure. So I'll answer the first, and I'll let Jamie answer the second. Yes, on the first one, you'll notice in that table, if you just added up all of the numbers in the right-hand column, it would be a lot higher than 10.93%, precisely because of what you point out. There are individual patients who experienced multiple categories of serious adverse events. We would only count that once when reporting that bottom line number of 10.93% of patients. It's not that 10.93 is the rate of the events, right? Because, a woman may go to the ER experiencing hemorrhaging, need a blood transfusion, and also develop sepsis, right? I mean, you could see how that one patient would have been in 4 different categories, but that would only count as one for the numerator. And when we're doing the math of like how many women experienced serious adverse events over how many women took mifepristone. So it's per patient per abortion. And the reason I say that second part is because there are some women who within this 7-year period had multiple abortions on multiple babies, right? So it's even different than, oddly enough, what we found in the insurance data is that some women were prescribed second doses of mifepristone, despite the fact that nowhere on the drug label and nowhere in any official guidance that we know of is it recommended to give a second dose, right? The FDA doesn't recommend this. The manufacturer doesn't recommend this. But we found thousands of women who were prescribed a second dose. We did find some abortion clinics on their website saying, if it doesn't work, let us know, come in, we'll give you a second dose, right? So some doctors are kind of freewheeling how they practice medicine and saying, we'll just give you a second dose.
So Jamie, I don't know if you want to answer then, within the other abortion-specific complications in Figure 1, that 5.68% of what some of those would include?
Oh, sure. So we looked at various sources in order to come up with our list. Most of the things that fall under that category are from the CMS diagnosis-related group 770 and 769 codes, which will mean more to your doctors than it does to me even. But those were the specific codes related to either complications from abortion or from miscarriage. And it's important that I mention that. When we're identifying abortions in our data set, right, we're looking for the use of mifepristone along with a diagnosis code saying that it was for an elective termination or an unwanted pregnancy. And then once we find that, we're looking at what happens to that woman, diagnosis, treatment codes, prescriptions over the next 45 days. Well, sometimes when she goes to a doctor following the use of the abortion pill, it's not being coded as a complication from the abortion. It's being coded as a miscarriage and complications from that. So it actually, in about 40% of the time when she shows up at the ER, after having taken mifepristone, we found that it was being categorized as a miscarriage rather than an abortion attempt. So those abortion-specific complications are mainly those DRG 770 and 769 codes, along with a few other codes that the doctors had identified as being specifically related to abortion, as well as some of the CDC's severe maternal morbidity indicators. A few of those codes would have ended up being categorized under that abortion-specific complications group. Most everything else was enumerated in those categories above. And there's a huge overlap between the women who show up in that last category and the women above. So if we had excluded that category entirely, it would barely have budged our numbers, even though it by itself says it's a 5% or so.
And let me just jump on what Jamie said there. A couple of weeks after our paper came out, the Charlotte Lozier Institute released a paper that also found, and I believe they analyzed Medicaid data, and they found, I think it was like 60 or 70% of mifepristone abortion complications were miscoded as miscarriage complications. And so, if anything, like what we found in our data, Jamie said it's roughly 40% of the time that we saw this. It's entirely in keeping with what CLI found looking at the Medicaid only data.
Yeah, and that's true. And what they also analyzed over a long period of time, well over a decade, that rate of miscoding or misdiagnosis within the emergency room has dramatically increased, as well as the increased use of mifepristone. And being a medical director of our local pregnancy center, these are very distraught women, distraught families, broken families, abuse that happens. And I would state that some of these women will throw away their mifepristone, or someone will steal it from them who doesn't want to have the abortion. So there's other reasons to get a second prescription. So that's going to be difficult to sort out completely. But let me ask you, Ryan, as a philosopher, I'm over in Eastern Europe right now in the Balkans, and I just spoke at a pro-life conference in Montenegro from medical people throughout the Balkans. And they're very happy this paper has come out and sing your praises, and yours and Jamie's both. But they state over here, even in Eastern Europe, that this paper is fake news within the medical communities. And, that happens in the United States. So is this an ideological issue, I guess? I don't have a better word to use than ideological, that people aren't respecting this data.
Yeah, so it's interesting that you make the international comparison point, because what's interesting is that after we released our paper, within a matter of days, there was an Australian researcher who had tweeted at me and Jamie and then emailed us saying that what we have found in the American data, health insurance claims data, corresponds very similarly to what he has found in Australian health insurance data, which suggests that, this has something to do with the nature of the human body and the chemical compound of mifepristone and what happens when the human body takes mifepristone, that it's, there's something there, right? The data is revealing something real and true. So then your question becomes, well, wait, why are so many people saying it's fake news, it's a bogus study, blah, blah, blah? And here I just think, look, there is an abortion distortion that is true when it comes to almost everything. Constitutional law, for almost 50 years, we suffered through an abortion distortion with how every other case gets litigated except for an abortion-related case, how the media talks about public health, with the exception of abortion, how the academy does this, one of the reasons why we didn't go through the peer review process for this study initially, like we're going to have subsequent studies that hopefully will go through the peer review process. We didn't want this to be leaked, and we couldn't trust that if we submitted it to a journal, that the editors weren't going to sabotage it, right? And this is a reality that researchers have to think through. If I submit this, it's technically going to be a double-blind peer review process. Are the editors going to honor that, or will their own ideological blinkers and prejudices make them leak this to Planned Parenthood or to Guttmacher or to whomever, right? So anyway, I'm not surprised that all the big abortion forces, both in the States and internationally, have tried to claim that it's junk science. But that's also why, at the end of the day, I don't want the FDA to take my word for this. I want them to say, look, this gives me reason to conduct my own study. And, I'm fully confident that if they do it, they're going to find what we found, because the data itself doesn't lie. And when you start looking at this woman was prescribed mifepristone on this date, and let's follow a 45-day medical journey with that patient, you're going to see the adverse events that we saw, and you're going to see that a certain percentage of those were serious. They were related. We excluded 73% or 72% of all the ER visits because they were either not serious or they were unrelated, right? And anyway, so yeah, I do think it's ideology. I think there's something about abortion that just skews public health and media and journalism and law and medicine, et cetera, et cetera. And I think that's just very unfortunate, because women deserve better than this. Women deserve to know the truth. Even if we disagree about abortion, they should at least know, for informed consent purposes, what risk they are undertaking by taking the abortion pill. And right now they're being denied that truth because the pro-abortion forces are so ideologically blinkered.
So the FDA and the HHS has made some kind of promise that they're going to review this paper and other possible research. And I don't know what the outcome of that review will be. But kudos, Ryan and Jamie, to both of you, because publicly you've stated that we need more research. And as medical physicians, we really appreciate that. So what are your hopes with the FDA and HHS response, knowing that, as you already alluded to, with the current prescription of mifepristone, you can get it online, you don't see a doctor. Some women are taking it well beyond the 10 weeks. And it's a wild, wild west out there. So what would be your hopes of what's going to come about with this?
At the very least, Secretary Kennedy has already said, based on the information that he's received so far, he said this in testimony in the Senate, that he believes the label should be changed so that at least the doctors who are prescribing this and the women who are receiving this are receiving accurate information about the risks. We would certainly hope that once the FDA verifies the serious adverse event rates like we're finding it, they would reinstate the safety protocols that were in place when the drug was first approved. So going back to the 3 in-person visits, the in-person dispensing of the drug and administering of the drug to make sure that it's actually the woman who was prescribed the mifepristone who is taking it, that it's not being used for someone else who may not have been appropriately prescribed. And then the follow-up visits to make sure that she's okay as she then takes the misoprostol, and 2 weeks later to make sure that the abortion was completed and that she's not suffering from any sort of infection or other health problem as a result. So we'd like at least to see that. Ideally more. It would be great, for example, if the FDA would say, you can't really tell for sure how far along the pregnancy is and whether there's an ectopic pregnancy unless you do an ultrasound. That was not part of the original safety protocol. It would be great if it were part of the safety protocol going forward. But ultimately, we'd like to see the FDA recognize this isn't safe for women, it's not safe for children, and it shouldn't be allowed at all.
One other thing that, and Brick, it goes back to something you had said, that, sometimes women would lose the drug, sometimes it would be stolen. One of the things that we have not yet been able to kind of like definitively show through the data, but there are indications of this in the data. And so we're still trying to think through what the research design would look like to be able to, really demonstrate it to the public. But the current version of telehealth mail order abortion pills really facilitates human trafficking and sex trafficking in particular. Because when you say, they lost or stolen, also realize it may be someone is putting, the patient who is undergoing telehealth is being somewhat coerced, or someone who really is a legitimate patient is then having those pills stolen so they can then be used for someone who's being coerced. The original protocols, when it was an in-person doctor visit, an in-person dispensing of the medicine, provided safety checks there to prevent against human trafficking and sex trafficking. So there's a whole host of abuses that the current regime is facilitating. And it was only when you mentioned that, in addition to the possibility that, the first dose didn't work, that it also was lost or stolen, that just reminded me that, one of the future papers that, we're still thinking through the whole research design on is how this facilitates trafficking. And I think that should be deeply concerning to everyone, whether they're pro-life or pro-choice. And, that's one of the sad realities of the abortion distortion here, is that many people, because they're so committed to being pro-choice, they turn a blind eye to the various forms of abuse that might be taking place.
Yeah, well stated.
Well, Ryan T. Anderson and Jamie Bryan Hall, thank you for joining us today on CMDA Matters. Great discussion, and we will be watching eagerly to see what FDA, HHS, all of the above are going to do with this, and that women will be protected. Women's health matters. That was one of the slogans of one of our cases, maybe the one that we took against the FDA with the Alliance for Hippocratic Medicine. So thanks for both what you do at the EPPC, and thanks for taking a big chunk of your time out today and joining us.
Thank you.
Yeah, happy to do so. Thank you.
Our thanks again to Ryan T. Anderson and Jamie Bryan Hall for joining us on CMDA Matters, and for their bold, evidence-based work shining light on one of the most pressing life issues of our time. We'll, of course, be watching closely as the FDA and HHS respond, and as further research continues to shed light on this critical issue. You can find a link to the full EPPC study and related resources in our show notes today. As Christian healthcare professionals, we're called to be both compassionate caregivers and courageous advocates for truth. This study is a powerful reminder that real data can expose real harm, and that both women and their unborn children deserve protection and dignity. Let's keep standing together, friends, as voices of hope, healing, and truth in healthcare, bringing the best care and the love and light of Christ into a broken world. If you'd like to connect with our growing community of Christian healthcare professionals or learn more about CMDA's resources and opportunities, just visit us at cmda.org. Hey, a quick question to all of you DEA license holders. Have you fulfilled yet your required 8 hours of continuing education on substance use disorder and treatment as required by Congress's MATE Act? All non-exempt prescribers have to fulfill this requirement before June of 2026. CMDA has a wonderful resource that fulfills this mandate, offering a faith-informed, evidence-based approach to caring for patients with substance use disorders. This resource is available free of charge to our members in the CMDA Learning Center. So check it out today. Next week, Dr. Brick Lance joins me as co-host again for a special episode that we recorded live at the Colson Center's annual conference in Louisville, Kentucky at the end of May. We had the privilege of interviewing several members of this year's Colson Fellows class to hear their inspiring stories. The Colson Fellows program is dedicated to equipping Christian leaders to gain wisdom and to live faithfully and act courageously. A mission that truly comes alive through these conversations in a man or woman on the street format. You don't want to miss it. If this episode encouraged you, I'd like to ask you to share it, or leave a review, or subscribe so that you don't miss upcoming conversations. You can also follow us on social media to stay connected and be most encouraged. I want to thank you for listening to CMDA Matters, where our mission remains the same: bringing the hope and healing of Jesus Christ to the world through committed Christ followers in healthcare. That's what matters to CMDA, friends, and CMDA matters. May you recognize this week that the Lord is with you and that He is for you to do His good work. Thanks for listening, and we'll see you next time, Lord willing, on CMDA Matters.
Thanks for listening to CMDA Matters. If you would like to suggest a future guest or share a comment with us, please email cmdamatters@cmda.org. And if you like the podcast, be sure to give us a 5-star rating and share it on your favorite social media platform. This podcast has been a production of Christian Medical and Dental Associations. The opinions expressed by guests on this podcast are not necessarily endorsed by Christian Medical and Dental Associations. CMDA is a nonpartisan organization that does not endorse political parties or candidates for public office. The views expressed on this podcast reflect judgments regarding principles and values held by CMDA and its members, and are not intended to imply endorsement of any political party or candidate.